Hello, dear students. I am Dr. Basil and Mathew, Assistant Professor, Department Pediatric and Preventive Dentistry, Vinayaka Mission Shankaracharya Dental College, Salem. Today, I will be taking a small class on cleft lip and palate. I will be dealing with the basic details that an undergraduate would need and for an exam point of view, where I will be covering the etiological aspects for cleft lip and palate, clinical features, and how to manage cleft lip and palate in a team point of. So we'll start with the class. The first slide will show the epidemiology, how common is it, cleft lip and palate. So according to the literature, it says it's the second most common congenital deformity, which is after the cleft foot and disease. Now in that case, we will see it is very common that it is there in 1 in 750 birth. That means if 750 children are born, you will see there are chances to see either a cleft lip or palate in one child. Now, in general, there are a lot of difficulties that a cleft lip and palate child or a patient will encounter, which include obviously the cosmetic difficulties, dental difficulties. For example, you will have a malocclusion, you will have missing teeth, that we will deal it in detail in the next slide. Speech and phonation, for example, the words like yes, t, there will be difficult in speech and the phonation. Probably the parent will be complaining that such words will be difficult for the child to speak loud. In swallowing, what we know that in the palatal defects, it will be difficult for the patient or the child to swallow, where there will be a continuous connection between the nasal cavity and the oral cavity. What the child will encounter is that whenever there is child try to swallow, there will be nasal regurgitation of the food. So that is the difficulty with the swallowing. Now facial growth, when we deal with the facial growth, there are few facial growth centers in the maxilla. There is a facial growth center in the nasal septum. So the nasal growth center in the maxilla will be affected in that case. So there will be reduced growth of maxilla and the entire facial growth will be affected. Now emotional, as a collective part of all the cosmetic, dental, speech, phonation, swallowing, facial growth, all of it will get connected to the emotional well-being of the child and it will be affect. Coming to the next slide, we will deal a little bit about the embryology of development of the lip and development of the palate. It will be very brief. Now, when we know that the lip development happens in the 5th week of intrauterine life, and we know that the lip develops based on the fusion of lateral nasal process, medial nasal process and maxillary process. As the picture shows, the green one shows the maxillary process, the red one shows the lateral nasal process and the blue one shows the medial nasal process. So the behind the small slide that I put is that you should know that where the clefts develop. Now when you see the last picture, you will see that wherever there is a fusion, for example, you have a fusion between the maxillary process and lateral nasal process, where that is here, and whereas the lateral nasal process and the medial nasal process is joining here. So wherever there is a fusion of two embryological tissues, you can have a cleft there. For example, in the lip, there are high chances of having left or right unilateral clefts. There are very less chance of having a midline cleft. So hope you understood, wherever there is a fusion, that is a maxillary process and lateral nasal process, there can be a cleft, and where there is a lateral nasal process and the medial nasal process using, there can be a cleft. But there are very less chances, or there is no possibility of having a midline lip cleft. Now we will come to the palatal cleft, probably we will get it more clarity about that. So you should know that it happens during the 5th week of intrauterine life. Now coming to the embryology of palate. Now in palate, we can divide the palate into primary palate and secondary palate. You can have the primary palate, again the development is almost similar between 4th and 7th week of intrauterine life, whereas lip we saw that it is in the 5th week of intrauterine life. Now when it is primary palate, you will see it is a triangular area. You can see this is the triangular area that is anterior to the incisive foramen. In the after development, probably the incisive foramen will be around here. So the anterior to the incisive foramen, and the area covers the lateral incisor to lateral incisor, that is 1, 2 to 2, 2. That is the lateral incisor to lateral incisor area, and includes the alveolar ridge of the incisor teeth. So that is the primary palate that we call, which develops between the 4th week and 7th week. Now coming to the secondary palate, everything other than this behind the primary palate is called as secondary palate, and it develops between 6th week of intrauterine life and 9th week of intrauterine life. That includes the whole thing, and the remaining hard palate and soft palate. Now when we see that there is possibility, you can see wherever, as I said in the case of lip, the cleft can happen along the fusion of the tissues. So now we can tell, as in the case of lip, we can have left as well as right anterior palatal cleft, whereas in come to the posterior palatal cleft, there is only possibility to have a median cleft or complete cleft. Okay, so that is the intention of having two slides about the basic embryology. So we have covered the basic embryology of lip and palate. We will come to the details how to deal with the epidemiology and the management in the later slides. Next, in general, the palatal cleft, the associated dental abnormalities or dental deformities. There are many other dental abnormalities, but the most common I have put it across. First is supernumerary tooth, that is 20%. Dystrophic tooth. Dystrophic tooth means a defective tooth, or you can say the dystrophic calcification, dystrophic mineralization. That is very common in the case of cleft lip and palate cases. Next is missing teeth. There are chances of missed out tooth. The normal dentition tooth will be missing, but there are chances of supernumerary tooth, as I already told. And everything will contribute to the malocclusion. As you see in the picture, there will be effect in the center, there will be reduction in the growth of the maxilla, and there is reduced number of teeth, there is a dystrophic tooth, and there are high chances of caries as well. So this is a combined form of dental abnormalities which the child will be facing with a cleft lip and palate. Now coming to the etiology of cleft lip and palate, we would call cleft lip and palate as a multifactorial etiology, because we will not be able to specify this is the reason for the development of cleft lip and palate. So we call it always as a multifactorial. But based on the evidences, based on the literature, we have found that these might be the contributing factors for development of cleft lip and palate. The first one we would say that non-syndromic. The next is syndromic. So the non-syndromic or genetic inheritance of cleft lip and palate. Now when we see under this statistics, it is a little bit confusing, but what it tried to say is that in case of cleft lip, isolated cleft lip, or cleft lip with or without a cleft palate, in case one parent has the congenital abnormality, there are chances that 2% of their children will develop cleft lip and palate. That is the predilection of having cleft lip and palate. Whereas if one parent and one sibling is already having cleft lip or isolated cleft lip and palate, there are high chances of developing a cleft lip and palate for the second child. That means 15%. 15% is very high predilection. That is 100 children, 15 children they are sure to have cleft lip and palate. Even though these percentages are there, recently the prevalence and the incidence of cleft lip and palate has reduced very much. These are the literature that is present. Okay. Now when we come to the cleft palate alone, if one parent has a cleft palate, there is 7% chance for the first child to have the cleft palate, whereas one parent and one sibling has cleft palate, 17% chance for the second child to have cleft palate. That means out of 100 live birth, you have 17 children with cleft palate. So that is the genetic predilection for cleft lip and palate, that is called as non-syndromic inheritance. Coming to the syndromic cleft lip and palate, there are few syndromes that is associated with cleft lip and palate. In the case of Vanderwood syndrome, whereas isolated cleft palate is present in Eppert syndrome, Treacher-Collins syndrome. Now, as I already told, it's a multifactorial. There are few environmental factors that can contribute to the presence of cleft lip and palate in a live birth. That can be presence of ethanol, that another than alcohol, rubella virus, thalidomide and aminoterin. All are the medications and pesticides that is available that is usually used. Now other contributing factors, we can call it as contributing factors, that is maternal diabetic mellitus and increased paternal age. So that is about the etiology or contributing factors for the development of cleft lip and palate. Now in epidemiology in general, when you take 100 cleft lip and palate cases, 50% would be cleft lip and palate combined, and cleft palate alone will be 30%, cleft lip alone will be 15%, and cleft lip and alveolus. Alveolus means the tooth bearing part of the maxilla or mandible is called as alveolus, which is 5%. Now there is something what we need to notice, that is the gender predilection for a cleft lip and palate. When you see, when the cleft lip is involved, there is a higher predilection for females and lesser predilection for males. Whereas in the case of cleft lip and palate combined, you have a higher predilection for male and lesser predilection for female. Whereas when you take a isolated cleft palate cases, there is a higher predilection for females. Okay. So that is about the epidemiology or prevalence or occurrence of cleft lip and palate in the population. Now that we have seen the etiology, we have seen the dental abnormalities, we need to classify the cleft lip and palate so that we will be able to convey the message among the professionals. There is a need to convey the message to the patients, but we need to convey or transfer the message among the professional or the dentist. For that you need to have a classification. The most common or the detailed or the simplest classification that we can understand and study is the Kernan's stripped Y classification system. It's called Kernan's stripped Y classification system. Now if you remember the embryology that I have already told you, you will be able to understand this classification. I have told there are chances of left or right unilateral cleft lip, but in the case of palate there is high chances of having a median cleft. Now in this you can see there is lip, there is alveolus and primary palate. Till there you have bilateral or either left or right, whereas in the case of coming to the hard palate and soft palate you have a median cleft. Those who remember the first few slides about the embryology will be able to correlate with this. Okay, so this is called Kernan's stripped Y classification. The professional message that will carry, for example, you will write the number 4, 5, 6, 7, 8, 9. That means there is a left lip, alveolus and primary palatal cleft, and there is a median hard palate and soft palate cleft. Or if you write like 7, 8, 9, it only means that there is a complete median palatal cleft, that is a hard palate and soft palate. If you write only 4, 5, that means only the lip and alveolus left unilateral cleft is present. Okay, so that is how you will be conveying the message based on the Kernan's stripped Y classification. Now I will show you the pictorial representation of the same thing. Now coming to this picture, if you see that you will be able to understand there is a lip classification. As per that it is coming till the primary palate and the hard palate starts from there, that is hard palate and soft palate, it is a median cleft. Now here you have a unilateral cleft lip, you have a bilateral cleft lip but no median cleft lip, you have a connected bilateral and a anterior palatine cleft lip, but when we come to the full palate or the posterior palate or the hard palate, you have a complete cleft lip and full palate according to the classification. That is a pictorial representation of the same classification that I have dealt in the previous slide. Now coming to few the clinical pictures, if you see that in the case of unilateral left lip cleft, you can see that only the left lip is involved, whereas in this case bilateral cleft lip is present. In this again there is unilateral cleft of the lip, then there is a bilateral cleft lip present. It's the same picture, you will be able to understand you will be able to make out the same thing. And the severity of this thing can vary. If you see in the first first picture, it is a very mild case of cleft lip, whereas in this case you will be able to see a very severe case of cleft lip, that is very severe. Okay, the patient images. Now the most important part of the cleft lip, that is the management, which need to be understood in detail, as well as it should be dealt by each professionals in detail. So when we deal about the management of cleft lip and palate, we call it as a team approach. Before it used to be handled by a single faculty, most probably a plastic surgeon or an oral maxillofacial surgeon. Now as the time develops, as the need of the hour says, we need to look into all aspects of the treatment. So when you read about the team approach, it includes everyone from the birth of the child till the full dentition has developed and the full aesthetics has been achieved. So when we start, it has an ENT surgeon, it has a plastic surgeon, a prosthodontist, a pedodontist, an oral and maxillofacial surgeon, an orthodontist, speech therapist. I'll just brief about everyone's role, and I'll go ahead with the detailed treatment plan. Now ENT surgeon, it is involvement of the nasal cavity is there. So any kind of surgery that is involving the nasal cavity and connecting with the oral cavity, we need to get the clearance as well as consultation of the ENT surgeon. Next, the plastic surgeon, the minute details of the skin and mucosal coverage, the scar repair, everything we need the help of a plastic surgeon. Prosthodontist will be coming mainly along with the periodontist. We'll have to fabricate the obturator or any other processes that will help to aesthetically as well as functional correction of the clefts that is required. The prosthodontist will take care of. In periodontist will take care of all the needs that during the primary dentition, including the restorations or extractions, adequate oral hygiene practices, and the preservation of the tooth. When the tooth is preserved, then only the arch can be preserved, the integrity of the maxillary arch can be preserved. So that age group, that mixed dentition, primary dentition will be taken care of by the periodontist. Oral and maxillofacial surgeon going hand in hand with the plastic surgeon and all other partakers in the team will be dealing with the surgical aspect of the child. Now, orthodontist, when it comes to the permanent dentition, orthodontists need to pull in regarding the fixed orthodontic treatment or any appliances that is needed along with the pediodontist. It's a continuous process, and along with all these practitioners, we need to have a speech therapist where the child is taught how to learn how to speak or how to pronounce words. That is also an important part. Now, in detail, we will deal with the treatment part. When we deal with the treatment parts, it can be divided into 4 stages. First stage will be maxillary orthopedic stage. Maxillary orthopedic stage that starts from the birth to 18th month of life, that is 1.5 years. It starts with the initial obturator therapy. I already told, either by a prosthodontist or a pediodontist, you will be fabricating an obturator. For example, the child will not be able to take a feed if you have a palatal cleft. There will be nasal regurgitation that happens between the birth to 3 months, and if you don't give an obturator, what happens, the child will not be able to take a proper feed, either from breastfeed or a solid food after few months. So there will be a detrimental effects on the growth of the child. So this has to be corrected by giving an obturator. This has to be modified as the child grows. Now that's something called a pre-surgical orthopedics. There's another name for this pre-surgical orthopedics. That the picture that you're seeing here is called a pre-surgical orthopedics, or it is also called naso-alveolar molding or NAM. It's a vast topic in itself, but the brief thing is what I would like to explain to you is that it is trying to mold the tissue as well as bone to get it approximated as close as possible, so that to avoid scar formation and a better aesthetic in the future. For example, in this case, you will see that the steri-strip is attached to the tissues and they are trying to approximate the tissues, and the correction of the nasal tissue is also achieved, so that when a plastic surgeon or an oral and maxillofacial surgeon does the tissue correction and the palatal correction, there will be less chance of failure or less chance of scar formation. So it has an aesthetic as well as functional importance. So this is an upcoming, and it is there. Most of the dentists prefer to do it in the situation, and it has to happen during birth to 5 months. So the important is that it has to be done between birth to 5 months of age, and after that if you do, the effects are very minimal. It will not contribute to anything what we desire. Now there is a surgical lip closure that happens between 3 to 9 months, done by a plastic surgeon or a oral and maxillofacial surgeon. There is something called a rule of 10. There are many rules of 10 in dentistry. One rule of 10 is that the child should be 10 weeks of age, 10 gram of HB and 10 pounds of weight should be there adequately for the performance of surgery and a good results. So that is taken care of by surgeons. Now there is something called a surgical palatal repair. This is a primary surgical palatal repair that happens between 10 to 18 months. That's a primary palatal repair. Now stage 2, it is done during the primary dentition stage that comes between 18th month to 5 years, where there is a complete primary dentition stage. During this stage, the treatment is usually taken care of by the pediodontist. There is adjustment of obturators to be done. In the case of maxillary growth, the obturator has to be widened, or it has to be changed, or it has to be modified according to the eruption of the tooth. That all is done by the pediodontist or a prosthodontist. Restoration of decayed tooth and evaluate eruption. Now in this case, evaluate eruption means you need to be careful to know that which all primary teeth are missing, which all permanent teeth are missing in the OPG. So this includes a total follow-up of patient with the help of lateral ceph, OPG and all. As I've told all the contributing factors, whoever is pitching in, but there are much detailed treatment plan where all the x-rays and investigations are necessary. Now coming to the next stage, that is mixed dentition stage. Again, a pediodontist plays a very important role in this. We need to see there is ectopic eruption of the teeth. Is there any supernumerary tooth that has to be corrected, that has to be extracted? Extraction is not very much indicated in the case of palatal cleft and lip cases. It should be done under watch. Only if it is needed at the end of the stage, you will do the extraction. Any malalignment should be corrected. Any minor corrections should be done during this stage. Correction of crossbite immediately should be addressed. If it is not done, there will be added reduction in the growth of maxilla. Okay, correction of crossbite is very important, and maxillary expansion, all the myofunctional appliances and orthopedic appliances should be started during this stage if indicated. Along with the discussion with orthodontist, a pediodontist should address this aspect. And secondary grafting. What is secondary grafting? We have done already the palatal correction in the case of a first stage. This has to be addressed if the palatal correction is not needed and there is a communication developing between the nasal cavity and the oral cavity. We need to do a grafting to cover up that communication between the nasal and oral cavity. So this happens during the mixed dentition. Now coming to the permanent dentition stage, it is mainly corrected and taken care of by the orthodontist, and already the whatever contribution that is given by the periodontist in the case of myofunctional appliance and orthopedic appliance, this treatment is taken over by the orthodontist for a complete correction, which include fixed orthodontic therapy, which is must for any cleft lip and palate cases. Next is dental and skeletal corrections, any major corrections that is needed, surgical or orthopedic corrections that has to be done during this stage. Now the last is cosmetic correction. This is done only after all the grafting procedures or the palatal correction, after the lip corrections, everything is done. The cosmetic repair is done during the last treatment. So this is the stages that I have covered, and this cosmetic repair usually taken by the help of a plastic surgeon or an oral surgeon. So these are the stages as I have already described. Stage 1 will be mainly of the orthopedic stage and the primary dentition stage. Then there is a mixed dentition stage, which includes all the corrections, that is interceptive correction that is needed, and then the permanent dentition, which includes the final correction and the aseptic correction. So these are the basic the things that are covered under cleft lip and palate. We will just recapitulate from the beginning once. So in the first slide I have covered about the introduction, where there is a basic epidemiology and what are the general difficulties that a child will face in the case of a cleft lip and palate. Then I covered basics of embryology, where how a lip develops, how a palate develops, and how is it contributing to the development of the clefts based on the left, right, unilateral, bilateral or median clefts. So that is the palate as well as the lip development. Now it was the general aspects of the dental abnormalities that is faced, then epidemiology, etiologies, and then the classification, which will help us to convey between the professionals, and it is related to the embryology of development of lip and palate, patient images and the pictorial representation of the classification, and the management, which is very important, which you should not skip if you are writing a theory paper. We should not miss etiology, we should not miss management and basic dental abnormalities that is faced for a cleft lip and palate child. And this is the detailed stages that is given for the treatment of cleft lip and palate. Okay, so this is the basic, and thank you very much for attending my class.